Well, good morning, everybody. Thank you for showing up this early to talk about this subject. And please forgive me because the idea of getting together, having an early morning run was mine, and certainly not that of the hosts. But I. My thought was that a lot of us are up anyway, and before things get going with school and all the things we have to do, that we could get together and have a quick chat about things. I want to I'm going to stop every now and then for coffee and this is my telemedicine studio. I'm really not circling the globe. So people talk about what it's like not to have feedback at all when you're, or a laugh track or something while you're while you're doing talks like this, and that's certainly one of the odd things about this for sure. So thank you. I'm going to, in a few minutes, I'm going to switch to share my screen. And if one of the things I wanted to talk about today, well, the first thing I want to say is that I want to thank Compassionate Cultivation for offering up this platform to talk about this important problem. I'm originally from Canada, and so I will throw in some humor here and there. It's intentionally the irony and sarcasm is the levity. I know it's a serious topic, but I'll pepper in some self-deprecatory or some other. Hopefully the jokes will be picked up. If not, please ask me. I never, even unintentionally, I wouldn't want to offend anyone. But so a couple of things that I want to share with you first is that well, first of all, these opinions are mine, right? They're not those of my practice. They're not those of Compassionate Cultivation. Even though I help out on their medical advisory board a few times a year with some discussion of what they're doing. The things I'm going to talk about today, my opinions here are mine, and they're not meant to be proprietary at all. I'm going to talk about CBD and other cannabinoids. The other thing is that I want to talk about to make sure people understand is that the use of there's no labeling for this product. This is a complementary treatment, and so what I mean by complementary is that it has there's a definition for what complementary medicine is. So this is a medical recommendation that has the potential for a therapeutic gain, and it doesn't unreasonably. And I apologize again for the double negative. So it should not unreasonably place a person's medical condition at risk. So so when any physician is talking about using a substance for a medical end, there are a few professional obligations as a physician. So I have professional standing. I have a license. I have a piece of paper. I have an I love me wall, like all professionals do, and the wall with all the certificates. I call that the I love me wall, but or the shock and awe and intimidate wall. But my obligation, using my authority, is to sort of to communicate these things as a complementary treatment, is to have an understanding based on my investigation about what is the basis for talking about this and how this is designed to improve any patient's overall quality of life. And you know, I will try to make a distinction between what is my opinion and what is based on literature, right? Because the idea of medicine, it's an art or an applied science. You're supposed to reason from what you know and what your experience is to apply it to people's particular situations. And I think that's like that even with, quote, standard of care medicine. The other thing is that my job is also to ensure as a professional that any complementary therapy is not contraindicated. So it's not like someone's going to, in my practice, just call up and say, hey, I want to try cannabis, right? You know, well, is it indicated? Is there a reason for it? And so those are two sort of essential things about complementary treatment. So one is there reasonable potential for therapeutic gain that doesn't put people at risk. And the other thing is that you know, I have a professional obligation to weigh risks and benefits in the literature and to also think about how it could affect other treatments. Because that's one thing to keep in mind is that no substance you give for a therapeutic end, you know, there's nothing that has no risk. So cannabinoids can interfere, for example, with the metabolism of other medicines, right? And so when someone is applying a complementary treatment, you have to keep that in mind. What are the potential you know, risks and side effects? So the other thing is that one of the things that's well known for autism specifically is that there's a broken or disjointed system for good data for behavior interventions that we as clinicians prescribe. So if ever people ask, you know, when you speak to a doctor and say, well, what can I do? We will start to mumble because if you come to a doctor and say, hey, I have pneumonia, what should I do? We should say, oh, antibiotic, bang, why? It's indicated. Oh, you have a heart attack, what should you do? Take an aspirin. Oh, there's good data to support that. So with the behavioral interventions, there is good data for many different behavioral interventions, but the data is very kind of gray. It's, you know, even though ABA has great data, what kind of ABA, how much ABA, how intense, what subtypes, what should I do for this problem? That gets into a level of weeds that as a you know, physician, you know, that's not our lane of expertise. And then, so it's not surprising that people go to complementary when people want to figure out what to do. It's not surprising, and it's very common in families and people who are treating autism that people start looking at the complementary environment. Now, as a parent, you know, right when you run into a wall of like what standard of care medicine can do, we're looking for what else can help, and that's, you know, very reasonable and important. And so let me switch over to, let's see, where's my Zoom app here? Now I'm going to try to switch over to what the sort of the meat of what I want to talk about. But I wanted to, it's very important in this kind of situation to get the sort of set the stage. And the other thing that I want to make sure folks understand is that I can't, I welcome love questions, right? So I'm married, I have 4 kids, I'm used to being wrong. I'm used to, the questions make me better. So I don't take offense to it. God does not whisper in my ear. And what I want to make sure that you all feel comfortable doing that. At the same time, I'm not going to answer personal medical questions because that would be kind of inappropriate. So if our discussion sort of wanders into that territory, what I'm going to say is I'm going to try to generalize from that to something that is perhaps where there's a nugget of where it's helpful for other folks. Okay. I will try to, let's see over here, share screen. If pictures of dogs come up, I apologize. I'm surprised they haven't come in yet. All right, so can everyone, can you all see my, my screen? Let's see. So I have the chat box back up now. Yay, okay, all right. So everyone's still awake? If you, that's a nice thing is you can multitask, have a coffee. How many people are wearing shoes? Can I zoom in a little? Okay. Oh no, you didn't mean that. Okay, sorry. My wife thinks that's really lovely. Is that better? Yay, okay, good, all right. So this is, I put this together during the last legislative session here in Texas where there are legislators who I have to comment, you know, and say that they're, you know, politics is politics, but as a group, they're very brave to take this on. And you know, and I think it's hard to second guess the difficulty that policymakers have in balancing opinions. But I put this some of this data together before, so forgive me, you know, about a year, you know, a year or so ago. So forgive me if it's a little out of date. But and forgive me if there's a collective well, duh, as I'm talking about this. So, but a part of the reason I want to share this is that while you're talking to others, so they understand. So I started talking on my own personal Facebook about how I was going to talk about this, and a really you know, and an old and an old friend of mine who makes me smile and laugh every time I think about him, posted a joke, a cheeky joke. He said, "Oh well, you know, the cannabis is for the parents, right?" And so you know, look, he took it well when I kind of responded back to him with a little bit of heat. And part of the reason I want to offer this this data is because you all are going to go and talk to friends and physicians and families and hopefully, you know, your physicians, you have friends who are physicians, and anyway, and if your colleagues out there, you know, this is helpful. I think it's helpful data to put things in perspective. Okay. So lots of people have autism. 1% is kind of the number that's used as a, you know, as a, you know, as a quick, but really like 1 in 88, of course, is a little bit more than 1%. So doing a little bit of napkin math, what I was telling the legislature is that so approximately 103,000 kids in Texas have autism. All right, and that's a lot when you know. That's a lot of kids, and you know, we won't even talk about the adults, but we should. So you know, guess twice, 3 times that amount, and there are a significant number that have some cognitive impairment, and that. So when we talk about epilepsy, right, which is also a little bit less than 1%, and 14,000 or so, given the statistics that we know about treatment refractory epilepsy, and I should probably change that because the name has changed. But you know, when originally the CBD, the medical cannabis, the compassionate use, the low THC cannabis law, call it what you will, was passed, that was meant to address this number, this 14,000. So when you talk about the numbers, we're talking about a much really I mean, it's a lot more kids. And so and what about insomnia? All right, so I'll come back to this point over here. So insomnia, and I don't really have to tell this group, I'm sure, insomnia is very prevalent in people with autism. And let me take a step back. So my perspective on autism is it's not one thing, right? So autism is a group of symptoms. So for example, and we know this, all of us know this too well these days. So one can have a sore throat and a cough and no fever, and we call that a cold. And some people can have a fever, so for example, they can lose their sense of smell or taste, and that can be caused by a virus, or let's say they have a runny nose as well. We call that a cold, but it could be from a coronavirus, or it could be from a rhinovirus, or it could be from a metapneumovirus, or it could be, it could be irritation or allergies. And as I sit here and rub my nose for my allergies, and they are allergies, and just keep that in mind. So anyway, so the same thing with autism is that there are many thousands probably of neurogenetic disorders, or multiple genes, or epigenetic influences on genetic susceptibility, but there's but it's lots of different low denominator, small number of, so like very rare conditions, and we only can identify a small number of them, okay? So when I say autism, I realize that I'm not saying much, but it's a group of symptoms and, that we put together. And so, but I think one of the more common problems that people and families have when they have someone with autism is insomnia, and that's not news. But it is news for lots of people who don't live with autism. So 60 to 86% from when you're looking at it as a sleep specialist too, it's very, very prevalent. Now, you'll see that it's 2 to 3 times greater than typically developing children. So that's a good question about why is there so much autism in sort of standard issue kids, but it's another story. But, and if you have a kid with insomnia who's, it impacts their development, it impacts their behavior, no parent can sleep with both eyes closed, right? So nobody's resting. And so if you use these numbers, there's a lot of kids with autism and insomnia in the state. And there are many families, and sort of, based on the number of kids and the number of other people, number of family members who deal with this, it's a high burden. So what do we do for this? Well, as pediatricians, what medicines are FDA approved for insomnia? None. The medicines that are typically prescribed are antihistamines. It can be a little sedating. So melatonin is often prescribed. There's a clonidine, which is an alpha agonist. It's a sedating medicine. It's often used for ADHD, or it's a non-stimulant medicine that helps with ADD, but has a side effect of sleepiness. Well, the side effect is used to the advantage of people who, is used. So yes, so you often get a 2-for-1 because it can help with frontal lobe and executive function the next day. But also the SSRI type medicines, some of the anxiety medicines, then the ones that are more sedating, those can be used as well. And this is basically as far as what is used typically in general pediatrics. So antihistamines, 89% of the time, Risperdal, the antipsychotics, 5% of the time, clonidine, 4%. So, Neurontin, anti-seizure medicines, also Lyrica, those are commonly used by neurologists treating this. And again, there's no problem with giving these medicines. I'm not saying that they're bad choices. I'm just saying that, I guess my point is that the database for using, let's say, for example, clonidine for insomnia is based on an N of less than 40. I think it's like 29 or something. So when we say that something is a standard of care medicine, you have to understand the literature basis that these things are built on. And it's not a very solid base. All right, so the other point is that autism is expensive, and sleep problems are expensive. See, I even found a spelling problem. Oh, look, and grammar. So, and I won't even talk about the institutional use of psychotics, and weight gain and their side effects from the antipsychotics. But again, I tried looking up the other day about what the literature basis is for Risperdal for autism. And again, we're talking about the studies that I saw, the number of people who were in those studies is together, it looked like it was under 200 when I started adding up all the quickly the clinical trials. So we're not talking about huge numbers that led to an FDA approval for these medications. All right, so enter CBD and using it for epilepsy. All right, so I'm sort of taking us way back in the past. So this is from the I lifted this from one of the from the Lancet, from the CBD trial for Dravet. And one of the things that was pointed out in that study was the general improvement from when the people had CBD in mood, alertness, better sleep, decreased self-stimulation. So, and I think that they knew it, and this was put out there on purpose. I think, because I don't. It's one of these, when you, as a physician who recommends these medicines, I can't help but humbled is too arrogant a word. I mean, it's impressive about what these agents do for people's quality of life, and so I think it was important data for them to get out there about how this helped. And when I started using the compassionate use registry medicine for my patients with epilepsy, I saw similar results in a number of symptoms that are problematic for people with autism. Okay, so that's how this came out. Now, the other thing is that there's a biologic plausibility for using cannabinoids, and it's fascinating. And sorry, right? I should get the. I need the doormat that says "Don't bother ringing the bell. The dogs already know you're here." So forgive me, I didn't want. So anyway, it is mind-bogglingly complex. And what I'll do is later I'll put on my blog a link to some of the articles that I pulled together for doing the background on this. And these are articles from PubMed, so it's not Dr. Josh's silly opinion. This is based on published literature that is screened by cranky academic clinicians. And I'm being silly. If there are cranky academic physicians out there, if you've ever submitted an article for a peer-reviewed journal, you get back criticism that can be picky and complex. But the point is that it's reviewed by peers. That's all I do, peer review. There are other doctors who are out there who pick apart what you're doing in order to make it better. So that's the. But I call them cranky academics because we can be. It's all right. And but there is some significant biologic plausibility about using these agents, and so let me stop for a second too. I'm looking over suddenly at the some of the questions. I'll just take a little break. Right. So there's one person who's admitting to not wearing shoes. Isn't that great? I asked a kid yesterday in the office, what's the best thing about being at school at home? I said, how many days have you worn shoes to school? He said, none. He was really happy. Anyway, so trazodone, there's a question about trazodone. Trazodone is in the antidepressant category for sleep. And I'm sorry for not mentioning that particularly, but that's a good example of an anti-anxiety medication that is limited in its use for anxiety because it makes people sit aren't sleepy. So what doctor said, we have these patients who have anxiety and who can't sleep. Let's try that. So trazodone is also a fine medicine that's often used for insomnia. And about data showing an increase in seizures, I'll have to go back to that. There's no anticonvulsant that doesn't do that. the data about using in epilepsy, using CBD, just to take a step off of that off of autism for a second, is that there are a small number of people who are super responders, so about 10 or 15%. There's a broad middle where there's a significant amount of response, but there are always, and I've had that clinically where I've had, I'd say, at least 5 or so patients where the seizures got worse, right? So it's not common, but for some reason they can get worse, and behavior can get worse too. And so that triggers actually a good question that there's never, and that's why I tell people is always we're using a substance that is meant to get to a certain end, but it might not. And I need to know because I don't like zombies and I don't want your kid to be worse. So, so please let me know. My ego is involved. My ego is my goal is to for everyone for things to be better and for everyone to be happy. I don't have ego tied up in molecules. So that's the bottom line. So just to put things in some perspective, so the main cannabinoid receptors that are in the body are CB1 and CB2. Okay. Sorry, I'm going back to the pathophysiology. I'm going back to the picture here. And so what's very interesting is that CBD, okay, so, and forgive me for going to some basics here. So what I say in the office is that THC, tetrahydrocannabinol, that's the fun molecule, right? That's the one that gives people the euphoria and sort of
it's 8 o'clock.
Thank you, Siri. It gives you the psychogenic effects, the munchies, CBD, cannabidiol, which is the second most prevalent of the cannabinoids in cannabis. It is the not fun molecule. And what's interesting about CBD is that it does not bind very strongly to CB1 and CB2. So it's a weak agonist and kind of maybe blocks some of THC's effects to some extent. And it works on other messengers, on other parts of the cell in order to cause or to modify the metabolism of the neurotransmitters and to make and to improve functioning. So so CBD is even more complex and not really well depicted on this, but cannabinoids at all of them are, if anyone's ever heard of arachidonic acid, right? So so that's mentioned here, but it's part of this the endocannabinoid. So endo means that it's your own cannabinoid signaling system. So our body has cannabinoid or arachidonic acid cannabinoid functions that help to modify not just nervous system function, by the way, but also immunologic function. So I think getting beyond the politics of cannabis is going to be very interesting, so that we can understand what this. It's almost like the hidden neurotransmitter system that has come home for us to finally talk about. But there's a lot of connection. Anyway, so I'm taking myself down a bunny hole of my own thoughts this morning. But so there are a couple of things to keep in mind when people are so there was a couple of pediatrics articles where they talked about the ethics of using cannabis in children. All right, so I want to talk about that just right out there for a second. And the two most common ethical problems as a physician and as a parent, I mean, of course, but they're more explicit for physicians, is one, what is there besides biological plausibility, what are the risks, what are the benefits? is this something that is going to help? Because you don't want to cause harm. And what are the long-term risks, right? And that's an important thing to consider. And then there's also the question about what are you getting? So the compassionate, one of the things I think that's under-recognized about the compassionate use program is that it's not just that the THC is up to 0.5%, usually 0.4%, but that's another story. But when you get commercial CBD, like if you order it, like a CBD itself is no more regulated than my coffee, okay? There could be, as a nutritional, right? There could be, you don't know really what's in there. There can be pesticides, leads, fungus, all these things. You have no idea. I'm trusting that there isn't pesticide in my coffee, but I don't know. All right. So drink up. So, but when it comes to a medication, right, as a physician using my authority, I think it's very difficult to recommend to someone in this kind of situation, oh, go get, Johnny Red Eye from the Holy Joe store down the street. Get electric lettuce from Frida, who sells it out of her garage. I don't know. There's no Frida. I'm just pointing a direction. All right. Please, no one geolocate where I'm pointing and get. Okay. So, all right. So that's the other thing. So I think those are important considerations. And the other consideration I think that's important besides that is what's the data, right? So we have, and I think that there is enough data to really be able to talk about this much more openly. So this is from an Israeli study from 2019, where they looked at, are there weaknesses in the study? Absolutely, it's based on parental report, right? Right, and parents never can be trusted, right? We don't, but I don't think that you guess from my sarcasm that that's not true. Bit bigger, hard to see. Bit bigger, hard to see. Okay, wait, a second. We'll go. All right. So, this Israeli study looked at. Now, remember, what they're using is a 20-to-1. So they're using so 20 of the proportion of CBD to THC is about 20-to-1 that they were using and looking at this for people with autism. Is that okay? Yes, I'm going to put this also. I think this is being recorded, and I'll put the data itself on my blog with citations too. So the important thing to let me walk you through this is that what they looked at the kids with autism, and they looked at change in 6 months. So they looked at and I think the importance of 6 months is to look at, are these changes stable over time, right? Was this just something that helped for a week or 2 or 3? No, let's look at 6 months. So let's look at some of the baseline. All right. So when you talk about the prevalence, right? So this is the numbers, right? What percentage had rage attacks, right? And it seems kind of like the epilepsy data in the sense that there's on one side of the bell curve, on the left side, there are a few super responders, right? So sleep problems, right? 20%. That's the best you can say, right? 20% the symptoms disappeared, but there's a significant improvement that's in the middle. And the thing to remember, no change or deterioration, that also does happen. So the thing is that no one's promising anybody a one molecule fits all kind of situation. So, but these are large in my, as I said, compared to Risperdal or some of these other numbers, these are not small numbers compared to clonidine. These are not small numbers. These are probably more kids than were in clonidine studies put together. This is actually also kind of very, it was a nice way to depict what they observed. So if you're just looking at sleep problems and looking at before treatment, let's break down how difficult, or how was their sleep? Did parents rate it as severely difficult, moderately difficult, none? So just think of this as neutral, and good or very good. And during treatment, right, I guess the parent same group was where they were asked again. And the thing is to look at the shift of the percentages, look at the shift of the numbers down here. So, so an extra 7 kids, or 9%, where they went up to 9% for the people who were very good, right? So, to promise people that things would be perfect is unrealistic and unfair. But I want you to see the shift down here to improvement. Eating with appetite, right? So that improved. Concentration on daily tasks. Well, what's interesting about when, I think it's been described in the insomnia literature for kids with autism, is that when kids sleep better, their social skills improve. There are a lot of other neurocognitive functions during the day that improve. Oh, guess what? When everyone sleeps better, our frontal lobe function and concentration improves. Well, guess what? People with autism, it's a similar kind of experience. So I don't know if this is a primary effect or secondary from the improved sleep, but I guess at the end of the day, my question is, who cares, right? Well, I mean, yes, it's good. We'd like to know, but I'm just happy that concentration is better. Sorry, I was just looking at the time. And then bowel activity, which I think is a significant observation with one of the main, we'll talk about side effects. Did things get worse on the whole? It doesn't look like things were tremendously better. But there isn't a statistically significant difference. Although when you eyeball it, it looks like, well, maybe, you can't make a claim in that sense. But it doesn't look to me, looking at the numbers, that things were worse. Now, this wasn't a prospective study that was designed to show differences. And same thing with appetite. But what about the so keeping these things in mind? I think part of showing this also, as far as appetite goes, has to do with comparing to Risperdal or some of the other antipsychotics or the SSRIs, which tend to increase appetite. So the point is that this is not statistically significant as far as the difference goes. But my guess, it's hard to quantify this, but if autism helps with things, if CBD and the low THC CBD helps with anxiety and sort of fussiness and rigidity, this could also be describing how flexible people are with what they're eating. So these are great questions. I'm going to come back to some of the questions that are scrolling up here. So one of the just so in case people have to run, so looking at change of medication use at 6 months, how many stopped taking antipsychotics, right? So parents always ask me, well, why am I doing this? Am I going to be able to come off the medicine? Okay, 75% don't change. Antiepileptics, right? 6 months, and the thing with antiepileptics, I mean, with anticonvulsant medicines, I can understand why 6 months is kind of a short horizon for judging whether, because if a child stops seizing or has decreased seizures, I'm just happy to have some calm seas for a few months, and just let's just say, without going into too much details, I kind of when it sounds like I'm speaking personally in the first person, I do walk the walk, not in autism, but that's another story. So so forgive me if I break into first person and people, I don't mean to take liberties. I do, as do a lot of professionals, walk the walk, but that's another story. So hypnotics, right? There are some people who have had their dosages increased or stopped. It does happen, right? But it's not, the general rule is probably not, but maybe. And that could also, some of this could also be due to doctors' reluctance to just rely on, certainly for anti-epileptics, to rely on monotherapy. So there probably is a lot of thinking that goes into why these numbers look like they are, but I bet that someone could quantify the savings to the universe by looking at this kind of tendency, this pharmacologic data. Okay, so this kind of, this is right from my highlighting of this, so sorry for the blue, but just to talk quickly about side effects. The most common reported side effects were, so about a quarter of people have side effects of at least one. So restlessness and sleepiness during the day, and that could be a dose or a scheduling kind of problem that can be manipulated. Psychoactive effect, increased appetite, 3%. Digestion, 3%, dry mouth, 2%. My experience is that dry mouth may be a little more common. I mean, it just could be I'm guessing. I have about 150 or so patients in the registry right now. But, remember, anytime you make a change with people of one thing or another, there can be placebo effect too. So I have no idea what this would be compared to the placebo effect. And that's also something that's important to keep in mind as far as the weakness of these kinds of observations. That's what I'm saying. This is an observational study. It's not a placebo-controlled study. So if, in migraine studies, for example, there's a 20% placebo response rate. If you just give someone something and just knowing you're in a study can improve certain clinical factors. So I think it's important to sort of keep this data with not just with a grain of salt, but a little bit more salt. But I think the important and why do people stop using it? No therapeutic effect. So that 70% of people who stopped was because it didn't help. Side effects, 5, and a certain number of people stopped with the intent to return. And I find often that because of the cost is a major reason why people stop. The other thing I wanted to point out is that this is as I said before, is that their data in Israel is using, it looks to me like it's using basically like a 20-to-1 preparation, so 20 of CBD to 1 of THC. And then one of the great things here in Texas is we can also recommend lower CBD ratios, and meaning like 3-to-1. And what I found is that changing that balance of the 20-to-1 and to 3-to-1 to 1-to-1 can help with some of the restlessness, some of the sort of the activating. I talked about how CBD works a little bit differently than THC, and lowering the CBD, if there isn't that much, if epilepsy isn't an issue, can help with some of the side effects. The other thing that they didn't point out here, and I have to go back to the article, is what kind of oil they used for the tincture. Many GI side effects can be fixed by switching from one oil, like if it's an MCT or coconut oil. So the data from MCT diets for epilepsy is that the MCT oils, so medium chain triglyceride oils, which are often like coconut, those can impact your appetite and have GI side effects. So switching oil can make a difference. Okay, so God is closing my vocal cords, or nature, or Darth Vader is reaching out to get me to be quiet. Let me, I guess, like go to some of the questions if that's okay. Is Big Sister still there?
Yes, Dr. Rotenberg, I am still here.
Great. Were there any questions from Zuckerberg and Facebook? Or I don't know if he's watching. I'm just being silly. I don't know. I can't see those.
No, not at this time. Some of our panelists have asked, someone asked if this would be available later to save. Of course, we'll have this available. Amy Falwell said, with the 20-to-1 in this study, do we know the number of milligrams of CBD per dose per day?
Yeah, I think it's pretty similar. I'll put that up. It's similar dosing to what I've been using, and I'll put that up later. I don't know which of my labels here. I'm afraid to see what would come up here as far as other topics I've been working on. But it's similar dosing to what we use here. For Epidiolex, for example, the FDA approved CBD only treatment for Dravet and Lennox-Gastaut. Those studies, as far as CBD, went to up to 20 milligrams per kilogram. And so if you do the math, that is a lot of CBD. and for someone to afford that, so I'm going to bite the hand that feeds me right now. I know Compassionate Cultivation would like everyone to go out right now and purchase 20 milligrams. No, but it's a lot of that's expensive. And my as I recall from looking at this article, it was about in the range of where we're using clinically, like up to 20-to-1, half of a mil. So 50 milligrams, 70 milligrams of CBD, and maybe a little more THC in their preparation. Actually, but roughly the same dosing.
Okay, great. One of our questions is, what is your recommendation on spacing CBD with meds at least 2 hours apart?
I don't see any reason to do that.
Okay.
I guess that may follow up question is, what's the biologic reason to do that? It's a question I've wrestled with since I've been doing this, with humility, I am asking why, right? So because the medicines, like, let's say for example, like clobazam, it has a long half-life. The CBD interferes with its metabolism, but it's not that short. It's not that short acting, and so whether you give it 2 hours before or 2 hours after, I don't know. There's certainly no data that I know of that shows that anticonvulsant control is better dosing it in that way than otherwise that I know of. And I would love for someone to teach me so I could do better.
Yeah, Michelle is saying that she said using the same liver enzyme to metabolize, most CBD companies recommend spacing with meds.
I know. I absolutely understand that, but I don't know why they do that, what they're basing that on. Are they perhaps they're worried about like overlapping side effects, like that people accusing their sedative side effects. From what I understand, the CBD and THC are extraordinarily safe. They don't suppress breathing unless you drown in it. So, kidding aside, I'm sure it's possible to have a significant overdose on it, but it's not and certainly one can take an overdose and have side effects and need hospitalization and certainly if that happens, you want to call your doctor or call poison control. But I don't know biologically. I know they do it. I don't really understand why.
Yeah. Another question we have is, do these studies apply to adults with autism? We actually had 2 questions regarding adults with autism.
There was one study that I saw that was published that where they looked at the feasibility of using CBD with autism symptoms in adults. I know there's one out there, but I didn't review it for today. But I'll put it in my my literature collection that I'll link to.
Great.
Although Dr. Harkins is there. Oh, hi, my father-in-law. Hi, Papa.
Yeah. So Dr. Harkins is asking, what about terpenes?
So, and what about terpenes, Dr. Harkins? So terpenes are the essential oils. Okay, so that we have in lots of plants. It's what gives blueberries their flavor. It's what gives lemon the part of the smell and allure of lemon. And so limonene, for example, is a terpene or an essential oil. I don't know of great data um, that says like how to dose that or how to use that. I'm sure they have some activity and effect. And another question that comes up often is what about sativa versus indica? So I know that Compassionate Cultivation, they use, as far as I understand, use a blend. Um, there are different claims made about indica versus being more sedating than sativa. And I don't see that there's a lot of, again, I'm talking about the data, and just having prescribed CBD. I think that there might be some truth in general that sativa may be a little more sedating than indica, but I've seen the reverse, and I've seen people respond to the CBD and to a CBD preparation and have the opposite reaction than you'd expect. And to the extent that what's in the oil is in the oil, again, I have to make an assumption that that's the case. I would hesitate to. I always tell parents that it may or may not have that effect. I don't know. I'm very hesitant to use my authority to say only use this or use that. So, um, but from what I understand, compassionate cultivation still filters out their terpenes, and it's an active area of discussion. It just, terpenes do add more variability to the what kind of end or what are the clinical expectations. And for the Israeli study, I don't know what terpenes, if any, were in them, but I guess I could reach out to them through email and ask. It's a good question.
Yeah, it's great. Our Plus products do contain terpenes, and our terpene profile can be found on our website. Another question, thanks for answering that, Dr. Rotenberg. Another question that we have from Zach is, the data was presented for Texas only. Do we know what is happening in other locations?
Oh, so the data, all of this data is an Israeli study, right? And I'll give a link to that so people would know what and of course, Israel's very diverse, and and it's a small country, so about the size of Delaware, so it's a good question about how we can generalize, right? And my data, of course, my personal experience is just, of course, for Texas. So I, in the United States, because of the legal status of CBD and it makes doing research very difficult. So I don't think that there is a great U.S. experience yet.
Great, thank you. Another question we have, and I think we have time maybe for two more, is can you share any experience regarding Medicaid or health insurance covering medical CBD?
Oh, yes, very quickly. They don't.
That's right.
So that's, again, sarcasm, irony, bitter irony. They don't. And certainly until the laws about THC are changed, I don't see that as even being something that would happen. I will tell you this experience, though. I have had patients with Lennox-Gastaut or Dravet who, before Epidiolex, so Epidiolex again is the FDA-supplied medicine, and insurance does cover the FDA-supplied Epidiolex, okay, to the extent that the insurance covers it. If there were comorbidities, right, when there were patients, of course, to save their resources, they switched from using the Texas Compassionate Use, the teacup-based program, to Epidiolex. And then at follow-up, they said, Dr. Josh, could we go back to using a little bit of the other stuff, because that helped with our child's sleep and behavior. So and that's where the plain Epidiolex that is activating often, and because of the dosing also, and because of the oil, it also can have, I've seen GI side effects, and sometimes it's hard to tell how much of it is GI and how much of it is behavioral activation. So that's, I guess, my experience with insurance coverage is that it's not always, it's helpful, but it doesn't answer a lot of the questions, unfortunately. Has anyone had experience with a healthcare savings program helping to pay for CBD? So Christina has said yes.
Yes, I believe some HSA, we do accept HSA and FSA.
Do you accept barter, like chickens, or no?
Another question is
tonic water.
what do you tell patients using CBD THC products in driving, particularly CBD?
Okay, well, so if we're just talking in general about CBD as a molecule, so CBD is not psychoactive. CBD is not impairing, that's sort of my general perspective on that molecule. Certainly no more than any other anticonvulsant. The big question is, and remember, Texas is a self-report state. So for epilepsy, for example, I'd say the bigger question is how well controlled is the epilepsy. So that's where that comes up. There is of course a risk that if you're taking the CBD and THC product, and if you're stopped, and if they, for example, for some occupational drug testing, a lot of the cheap drug screens can't tell the difference between CBD and THC. So that's presented a problem for at least one of my patients that was unfortunate. I really, be cautious about saying it's okay to drive with THC on board. I don't think that's a responsible thing to say. Did I avoid that question?
Very nicely done.
Did I get away?
Yep. Let's see. I think that actually answers all of our questions right now that we have. There will be an opportunity to ask follow-up questions, and we will be posting this on live on our Facebook channel for viewing later today.
Great.
So it's one of the questions is, so THC is better for adults with slight autism?
I'm going to take apart that question and answer the question. Forgive me, because I'm going to try to answer the question I want to answer instead of that question. I don't. Is it authorized in the state of Texas? Is autism is it an age-dependent diagnosis for the teacup program? No. You could be a 90-year-old with autism and you would still qualify. Is the might pure CBD alone be helpful? it could. I don't know and you'd have to go back to the Epidiolex studies. Of course, those are people with epilepsy too, right? And that seemed to show some benefit behaviorally. And so the studies from Israel indicate that the CBD with some THC help. There would be some great areas to look at as far as looking at adults with autism before and after. What happens if you have a balanced a 1-to-1 or 3-to-1? I think that's an important area of study, and hopefully we'll be able to do that with some amount of retrospection in the next year or two. But I mean, I think the most important thing for us and for other again, I want to, if I'm talking to a cranky clinicians, there is data that this is a reasonable thing to use as a complementary agent once other things have failed as a prescriber. That there is data, if there's biological plausibility, there is data to support it, and there isn't a large risk. The risk of side effect is low, and as far as we can tell right now, and certainly in comparison to other antipsychotics that have other significant side effects, it appears to be very favorable. So again, as a complementary agent, using it as a physician, and also knowing about the illness and the other medicines, I think that that this is the benefits for people and families are potentially very, 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 very great.
Thanks, Dr. Rotenberg. And we do appreciate having you. I know we're kind of running a little over on our time, but I wanted you to speak to anyone who's listening that may want to go through the consultation process with you, that one may either be ready to talk to their doctor or looking for a doctor to prescribe. What does that process look like? Do they, can they go to your website and get a virtual?
Yeah, because we're all locked in the house right now. So look, if you want, so first of all, not all physicians, not all specialists in Texas can prescribe or recommend the compassionate use program. There are some of the doctors who are excellent doctors who I would go to, I would send my child to, I would send my family to. They work in places where they're not allowed to recommend this, and that's unfortunate. So if you want your doctor, you can keep them. Especially because if you have a chronic illness, I wouldn't want to take away anyone's main physician. But I do play nicely in the sandbox, I hope. And so I would suggest everyone sort of discuss this with the specialist who's managing their condition. And I'm happy to see people, adults and kids with autism or epilepsy or other neurologic disorders, because I'm board certified in epilepsy, blah, 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 sleep, very nice. Hi, Mom. But brain injury, but there are certain qualifying conditions that people have to meet according to the state of Texas. So that's important to stay on the right side of all that. But I've been doing telemedicine visits with people. I know Dr. Harkins is on today. She's in San Antonio. She's a developmental pediatrician. She's awesome. And a longtime friend of mine. I know she's on the program, so call her as well. Anyway, speak to your doctor about it. But you can call my office, and we'll get folks in, and I'll still be here in my telemedicine studio.
Thanks, Dr. Rotenberg. We appreciate it. We appreciate you.
Wash your hands. Wash your hands, everyone. Keep washing.